I'm one of the dermatology third-year residents, and I'll talk to you a little bit more about my path to derm because I was in your shoes not too long ago. But today I'm going to talk about inpatient dermatology, which is my like little love within dermatology, and I think really applicable to all of you, especially while you're in residency, but also potentially in your future careers. I'm having trouble clicking. There we go. I have no disclosures. And my objectives for you today, first of all, is to convince you that derm is a subspecialty of internal medicine, and in my opinion, the best one. And we're always hoping to recruit more IM residents into derm. So hoping this can, give you a little bit of a taste of what we love about it. And then we'll go through some of the common inpatient derm consults and their management and empower you to manage some of it, at least by yourself. So when I was in medical school, I thought this was derm, like Botox, filler, things that I didn't really want to be a part of. I remember my mom suggesting I go into derm, and I told her I didn't want to sell out. But what derm I think really is, and what I love about it, is this fascinating field where you see really interesting and kind of sometimes like very aesthetically beautiful skin disease that then gives you a window into that person's systemic disease. So this patient on the right is someone who I saw in clinic a few months ago. And they have this really kind of like intricate annular rash, meaning like they have these little kind of ring shapes that are grouped together. And this person ended up having either disseminated granuloma annulare or sarcoidosis, and that he's still kind of being worked up for those. And so I think I'm hoping in this talk that we can shift maybe your impression of derm to being something that is really a subspecialty of internal medicine and a place that, derms can be really helpful in helping diagnosing and managing systemic disease. So my path to dermatology, so I was in your shoes not too long ago. I did internal medicine residency here from 2015 to 2018. And if you look in the bottom kind of right-hand corner of this picture, you can see there's Ken Steinberg and there's me. And I don't know if you guys still do this pack med retreats, but that was at the end of my residency. I then went on to do a chief resident year at Roosevelt as the outpatient chief. And then I worked as a hospitalist at Northwest for a year. This is my very happy last day as a hospitalist there. I moved to Philadelphia for a year as my husband's also in medicine. He was doing a fellowship there, and I worked as a hospitalist at Pennsylvania Hospital. And then I came back and joined this wonderful group of people and started my derm residency a couple of years ago. I started internal medicine not really knowing what I wanted out of it. I know I wanted to be a subspecialist, but I couldn't really figure out what I wanted to do. And I did a rotation in derm my third year with Dr. Sheena Hara at the Fred Hutch derm clinic. And I just fell in love with it. I thought it was the coolest subspecialty I rotated through because you do get to have a really active role in diagnosis of rare conditions. There are a lot of treatment options available, which I sometimes found I couldn't find in some of the other specialties. And you get really tangible benefit from the kind of interventions you enact, plus getting great continuity of care with patients. So my selling points for derm, and happy to talk to any of you more about that if you do have an interest in it. We're going to talk today about inpatient dermatology, and you will see in this talk that inpatient dermatology really encompasses kind of all subspecialties. We're going to talk about things that involve pharmacology, rheumatology, ID, hemonc, nephrology, kind of every subspecialty you can think of. And even in what we cover today, it's not going to be a comprehensive talk on inpatient derm. We're going to, do our best, but I am like already remembering things that I forgot to include that we see on a regular basis on the inpatient side. And I'm going to try and make this relatively interactive with case-based scenarios and questions. So if you can either unmute or put your answers in the chat for some of these questions, that would be great. So case one, this is a 28-year-old male who's admitted for cellulitis complicated by an AKI, and he presents with a pruritic rash. He's been treated with ceftriaxone for the past 4 days. He recently started buspirone as an outpatient for anxiety. He's been afebrile for the past 2 days and his white count is normalized. His creatinine is down to 1.6 from 2.2 on admission. What questions might you want to ask him? Or what other things might you look for on his exam? Any periorbital swelling? Great. So looking if there's facial edema, you might also look for hand edema. History of any allergies? Great. Are there any other things he's reacted to? And involvement of mouth, mucous membranes, groin. Great. So you're looking, are there any complicating factors? And we'll talk a little bit more about that. So what is your diagnosis at this point, based on the information you have? Drug eruption. Great. Great. Okay, you all got it. And we're going to talk a little bit more about what kind of drug eruption. What would you do for management? Would you stop ceftriaxone and trend his labs for a few days, continue ceftriaxone, or continue ceftriaxone and trend labs for a few days? B, okay, 1 vote for stopping the medication and trending labs, and 1 for D, continuing the ceftriaxone. Another B. A lot of Bs. People love labs. Yep, agree with loving labs, but I'm going to say that the vote for D was correct, that you can continue ceftriaxone in this case. So this would be characterized as an uncomplicated morbilliform or exanthematous drug eruption. So exanthematous drug eruptions typically occur within 2 weeks of the drug exposure. So you're totally right that you want to get a good med history, think about allergies that he's had in the past. And oftentimes the way that these look with that, what we sometimes will talk about maculopapular appearance, can look a lot like a viral eruption too. So that is also in your differential there. You guys hit the nail on the head that you want to rule out complicating features of a drug eruption. So fevers, lymphadenopathy, hand and facial edema, liver and renal dysfunction, eosinophilia, atypical lymphocytosis, and desquamation, as well. I don't think I put it on here, but like mucositis, oral involvement is really important, and eye involvement too. If it lacks those features, it's characterized as an uncomplicated drug eruption, and it is okay and actually recommended to continue the culprit medication. And we do not recommend that you place that medication on the allergy list. And that's because these are really benign eruptions. You can usually treat through them. And if you start adding medications to someone's allergy list for this, you're going to run out of medications to use in the future really, really fast. Sorry, I'm just going to plug in my computer. It's about to die. We do recommend trending labs for a few days to rule out any development of complicated features. And then, serial exams, if they were to develop mucositis, if they were to develop eye pain, desquamation, those are all things that, would warrant reevaluation. Uncomplicated drug eruptions are usually caused by antibiotics or antiepileptics, but really there's like a 100+ list of things that cause these. And then treatment, triamcinolone, 0.1% ointment twice daily, ordering in that big jar that Dr. Colvin mentioned, so they can get it all over their body. And then antihistamines may be helpful too for pruritus. We tend to prescribe antihistamines in higher doses than other specialties probably do. So you can go up to like 10 to 20 milligrams twice daily in someone with normal renal dysfunction. And you can even go up that high in someone who has some renal dysfunction, as long as you're kind of monitoring for sedation. Hydroxyzine as well for as needed for itch. This is how I make drug charts, and I think it's a really helpful way to go about it. First, you want to identify what day the rash started, more or less, and then kind of look back in their med history for the 2 weeks preceding that and figure out what drugs were new and what drugs are being continued, because most drug eruptions are going to occur when the medication is still on board. So in this patient's case, he started ceftriaxone a few days before the rash. He's still on it. That's probably your most likely culprit. He did have this new medication, buspirone, which, as far as I know, is not like a super, drug allergy related medication. But that had been on for like a month preceding it anyways. He has an uncomplicated drug eruption. It's probably not as likely. There are certain medications that like insulin, for example, that a lot of people are on that don't really cause drug eruptions. And some of those you just kind of learn with time. But really thinking about antibiotics, antiepileptics, and then time course for whether or not they're still on that medication can be helpful. So your patient's rash worsens. He develops a fever, mild cervical adenopathy, a little white count, no eosinophilia. His creatinine bumps again. His LFTs are up. What's the next best step in management? D, great. You got it. Okay, so we're going to stop his ceftriaxone. What's our diagnosis at this point? Great. Great. DRAS or DIHS. So drug reaction with eosinophilia and systemic symptoms is kind of the older term. And then the newer term is drug-induced hypersensitivity syndrome. They describe the same thing, basically. But features of that are fever, morbilliform rash. Eosinophilia is often present, but doesn't have to be. And importantly, eosinophilia can be present in just normal drug eruptions too. Atypical lymphocytosis, hand and facial edema, renal and liver dysfunction. And then you can get involvement of a lot of other organ systems too. So you can have myocarditis, interstitial pneumonitis, encephalitis, pancreatitis, thyroiditis is a big one. Features I want to just point out about DRESS is appearance. Typically the plaques are going to be a little bit like duskier or redder compared to like your run-of-the-mill morbilliform rash, but not always. And then that hand and facial edema is important to look for. And if there's facial involvement of the rash, I think a little bit more about DRESS than I would just a non-complicated eruption. And yeah, someone's pointing out that we're going to get to the time course in just a minute here. Importantly, you can get mucositis and some desquamation with DRESS as well. DRESS typically occurs 2 to 8 weeks after drug exposure. Antibiotics, anticonvulsants, allopurinol are kind of the big ones that we think about, but more drugs are also involved. It's thought in part to be related to viral reactivation, so HHV6, HHV7, EBV, and CMV. And it's a little bit like unclear what to even do about that, but just kind of a point of interest. Importantly, you can develop thyroid dysfunction, and so you should check a thyroid panel at baseline and then 3 months later because it can develop late. And we treat this with a slow prednisone taper, so starting at 1 mg per kg per day, but then kind of going down slowly after that. One of the answers in that question stem was skin biopsy, and that may or may not be really that helpful. Probably you're not going to see any really specific changes on skin biopsy, and so that's not necessarily indicated. Okay, moving on, we have a 51-year-old male who presents with oral erosions and dusky plaques on his trunk and extremities. What is your differential diagnosis? So I'm just going to pause and answer Austin's question here. He said, since he initially had an AKI, would initially fall under a complicated drug eruption and would have made sense to hold his ceftriaxone admission. That's a good question. And I think that part of the reason I included that AKI in that first question stem is because I think commonly in hospitalized patients, they are going to have something that could be a feature of DRESS, right? They're often going to have an AKI or a fever for some other reason. And so it's really putting the whole clinical picture together and thinking like, do they have several of these features that could support DRESS? And oftentimes that's going to take a couple of days to figure out, or just kind of like talking with the primary team or other specialty teams and figuring out what they think could be causing all the different things. For example, I saw a patient the other day who had like a slight troponin bump, probably from a type 2 NSTEMI, and the team had asked whether or not that was a feature of DRESS, and she didn't really have fever, she didn't have LFT abnormality, she didn't have anything else really going on to point towards DRESS, and so we said less likely. But some of these things do take some time and just monitoring to figure out. Shifting back to this case, what is your differential here? SJS, great. Any other things that could be going on here? I'm gonna just for HIV. Oh, those are interesting ideas. Yeah, syphilis can look a lot of ways. HIV can certainly, you can have oral ulcerations. I'm going to shift forward a little bit because some of this is a little bit of a guess what I'm thinking question because I don't think that these diagnoses come up that commonly for you. But there's a spectrum of mucositis and skin desquamation disorders that range from Rime and Murm to erythema multiforme to SJS/TEN. And Rime and Murm are reactive infectious mucositis and mycoplasma infection-related mucositis. Those are thought to be like reactive mucositis or like oral ulcers, basically, from infection. So Murm is from mycoplasma, that was what was initially described, and then subsequently other infectious triggers were identified. And Rime and Murm, they tend to have oral, maybe eye, genital, mucosal ulcerations, but kind of limited skin rash. Erythema multiforme is similar with that mucositis, but then has target lesions on exam. And that tends to be associated with HSV. And then on the other end of the spectrum is SJS/TN, which I think you guys are more familiar with, which is a drug rash. And you get this full thickness desquamation, so very skin predominant, but you do have a lot of oral and oral and eye involvement and genital involvement as well. If there's less than 10% body surface area involvement, that's classified as SJS. If there's greater than 30%, that's TN. And then if it's in the middle, it's SJS/TN. So on further history, this patient was recently started on lamotrigine for depression. His rash progresses and desquamates. What do you do at this point? And you can pick a couple of answers. A and D, okay. Great. I'm going to argue A, B, and D, but A and D, I think, are where the money is. And I put C in yellow because this is kind of a point of debate. So the most important thing is that you want to stop the culprit medication and you want to get them appropriate burns care, just like you guys thought. A skin biopsy can be helpful, particularly in ruling out other causes of blistering, like autoimmune blistering disease. And then there is some debate about systemic management. I was actually trying to look through the literature yesterday and find a good review article for you guys, and there was just like not great evidence anywhere. And so here at Harborview and UW, we do not use immunosuppressants to treat SJS/TN, but at other centers, some people do use etanercept or even prednisone or cyclosporin. But there's just not great evidence for any of those immunosuppressants really helping. There is an ongoing trial that we are a part of at Harborview to see, to look at the benefits of etanercept. SJS/TN typically starts within 2 weeks of drug exposure. We often, I would say usually do skin biopsies to rule out any other blistering disorders and confirm the diagnosis. Most important thing is to stop the medication and transfer them to the burns unit. This is just a pretty picture. Another kind of perk of dermatology is that you learn a lot of path. And this is what you would see on a biopsy of SJS/TN, where you see a subepidermal blister. So this is, to orient you, this is the epidermis up here, and this is actually also a section of epidermis. They're just kind of layered on each other. And you see these necrotic keratinocytes up through all of the epidermis. Okay, and then just a quick run through of a couple other drug rashes because I just think they're really cool. Has anyone ever seen flagellate erythema before? And do you know what might cause that? Mushrooms, yes. Okay, this is like a good step 2, I feel like, question. Mushrooms, shiitake mushrooms are one of them. Bleomycin, and then you can also see it in dermatomyositis, and you see these cool kind of like streaks, like someone almost has scratched at these areas, but they just come up on their own, which is a little wild. A couple other interesting drug rashes. So this is AGEP, or acute generalized exanthematous pustulosis. This occurs within 2 weeks of drug exposure as well. You get these superficial pustules and lakes of pus. It's kind of like a gross descriptive term, but I think fitting. the patients will often have fever associated with this, and it's typically associated with beta-lactams and macrolides, like azithromycin. Estrife is another interesting one. This is symmetric, drug-related intertriginous, what's the F, and flexural xantha. This occurs really quickly, so it occurs within hours to days of drug exposure, often again associated with antibiotics, and it's thought to occur in these areas because of increased drug excretion into the eccrine glands. Fixed drug eruption, you may have seen before, occurs within minutes to hours of drug exposure. And in this setting, you get this erythematous plaque, often or sometimes with a blister associated, that occurs on the same site. So the person always gets it on one finger, or they always get it on their lips. And it can be multifocal, so it can be in multiple parts of the body at the same time, but more typically it's just in one spot. And like you see here, it can be like it's really round, well demarcated, and has this kind of red to violaceous color. Often involves the oral and anogenital mucosa. This is just like a timeline of how to think about drug eruptions. As you know, I've said a couple of times, thinking about when the drug was started, and when the reaction started is really important to figuring out what drug is involved. And so fixed drug eruption, pretty short, hours to days or minutes to hours, estrife, minutes or hours to days, and then AGEP, exanthematous drug eruptions, SGSTN, more in the 2-week time frame, and then DRESS, like someone had mentioned before, it's really important to take like a long drug history, like going back 2 months to see what they've started on. Again, typically going to be something they're still on, but not always. Okay. Case 3. You have a 46-year-old woman admitted to AHD with a new diagnosis of AML. She's found to have this rash on her, let's say on her extremities on admission. You feel empowered by your recent derm didactics and decide to do which of the following? B. Great. That is correct. So you would want to do a punch biopsy rather than a shave, because the action that you're going to see isn't going to be in the dermis. That's where you're going to see the diagnostic features of anything that is on this differential diagnosis. A shave would be too superficial, and you don't really want to start treatment before you know what's going on, right? So this presentation with these purpuric nodules, papules, plaques in an immunosuppressed cancer patient has a pretty like consistent differential. So things that I would think about would be leukemia cutis, disseminated angioinvasive fungal infection, specifically Aspergillus and fusarium, sweet syndrome, a drug eruption, and that in part because these patients are often thrombocytopenic and they may just bleed into a normal drug eruption rash and make it look a little funky. Cutaneous small vessel vasculitis. And then in someone who was post-transplant, I might think about acute GVHD, again, because they can bleed into the rash and it can look a little bit different than it might in other patients. Importantly, this is a good presentation to page derm about after hours, and that is because if there is a concern for disseminated fungal infection, we could do a skin biopsy, send it for culture and KOH that night, and oftentimes it will result positive that night, and you can start systemic antifungals that night. So that is never a ridiculous consult question. That is always something that we would want to hear about and help you with. So let's just go through a few of the things on that differential. So, and Nikki, can you remind me what time I'm supposed to be done by? 10:30.
Sorry, mouse not working.
Okay.
It's like 10:40-ish.
10:40. Okay, good. So neutropenic patients are at risk for disseminated infection from Aspergillus and fusarium, which are both soil saprophytes. So they're fungi that are just found in our environment and decaying vegetation. But in neutropenic patients, they can't mount a response to it. It spreads all over their body and causes, not good things. They will often kind of get into the body through burns or surgical wounds, intravenous catheters, sites of entry. And one particular nidus for infection is in neutropenic patients is macerated skin underlying like a dressing can be a cause for primary cutaneous aspergillosis. And then when it disseminates, it can go all over the body to the nervous system, kidneys, heart, and cause really widespread disease. Skin lesions develop in about 75% of patients with fusarium and aspergillosis, and they can have this like really purple appearance, can sometimes look targetoid, and can sometimes even like blister a little bit. Patients will often have high fevers and just kind of systemic malaise. And yeah, and then Mucor, I think you guys have probably seen, potentially in your neutropenia patients, but also in diabetic patients. And that is going to look a little different, where you may have like an underlying sinus infection, you may have unilateral facial swelling, and erythema, but you will have those like areas of necrosis, often on the nose. Looking inside the nose is really important. But think about that in patients with diabetes. And I feel like on boards questions, it's often framed as like a person with diabetes who has like a hemorrhagic ulcer on their nose. Leukemia cutis is one of the other big things on this differential, and it can have that more like purple appearance like we saw in the initial picture, or it can have more of like a disseminated papules with like a little bit of a purplish tinge. It is seen in AML, ALL, CML, CLL, and portends a poor prognosis. Basically, it's the leukemic cells have gotten aggressive enough that they've traveled into the skin, and so usually is not a good sign. Most commonly on the head, neck, and trunk, but can be other places as well. And then this is just what you would see if you biopsied it. All of these little purple cells in here are all little leukemic cells. Sweet syndrome would also be on this differential. So sweet syndrome is also called acute febrile neutrophilic dermatosis. And in that longer name for it is very descriptive. So it's gonna be acute, you're gonna have a fever, and then you're going to have these, what we call juicy violaceous nodules packed with neutrophils. And you will hear in dermatology, we use all sorts of kind of weirdly descriptive terms, but I think this is a good one that if you looked at this nodule here, it looks juicy, right? It looks like there's kind of stuff in it. Sweet syndrome is more commonly seen in AML than CML. And it is also seen in non-hematologic malignancy cases. So it's seen in IBD, pregnancy, autoimmune disease, and it can be medication associated. And in some cases, it's idiopathic. In terms of other organ systems involved, the eyes are the main extracutaneous site that's involved. So think about an ophthalmology consultation in patients who do have eye symptoms. And then all the other organ systems can also get involved as well. I meant to say that the range for like how many of these are associated with malignancy is about 35 to 67% in more recent literature. So I'd say like close to a majority of these cases are malignancy associated. It is treated typically with pulse steroids while in the hospital, and then a slow prednisone taper. And then this is what you would see if you were to biopsy it. So these little kind of trilobed things are neutrophils. All of these are neutrophils kind of coming into the dermis and up into the epidermis with some edema in here as well. Okay. And then anytime you see a little like purple papules, nodules, oftentimes I think vasculitis comes to the forefront of people's minds, and particularly if that rash was located more on the lower extremities, I would think about that as well. So you would see palpable purpura in dependent areas. And oftentimes this can look more exuberant in the thrombocytopenic patient than it might in someone who's not. Cutaneous small vessel vasculitis and kind of vasculitis in general, I think could be a talk in and of itself. So I'm going to keep this a little bit brief, but basically cutaneous small vessel vasculitis implies that it's mostly really, tied to the skin, though that can be associated with systemic vasculitis as well. And what you get is immune complex deposition in the postcapillary venules that then cause complement activation, a neutrophilic inflammatory response, and vessel damage, hemorrhage, and tissue ischemia. And typically it's going to occur 7 to 10 days after an exciting exposure and resolves within 3 to 4 weeks in most patients who have this. In terms of what causes cutaneous small vessel vasculitis, 50% of cases are idiopathic. So this whole big purple area is idiopathic. And then infection is next, autoimmune connective tissue disease, a neoplasm in some, and then idiopathic in, the majority of the patients who present with this. So in all patients who present with palpable purpura on their legs, you should get a CBC with diff, a CMP, a UA, review their medications, and then do like a really thorough review of systems. If they do have systemic symptoms, and depending on their history, you might consider this additional lab workup, but you don't necessarily need to shotgun this from the start, as most of these patients are just going to have it be related to medication or an allergy or medication or a drug or possibly something we don't know. 90% of patients with skin-limited small vessel vasculitis are going to have spontaneous resolution. And then graft versus host disease. I would also maybe think about in a patient with a new rash with like more of a purpuric appearance in the hospital, but I think this is like a little bit farther down on the differential for those purpuric nodules. Again, in patients who are thrombocytopenic, their rashes can look a little bit more purple than other people. So I would think about it in someone who had undergone a transplant. GVHD is divided into acute GVHD and chronic GVHD. Acute GVHD used to be defined as GVHD that occurred within the first 100 days after transplant, and chronic being in the 100 days or more. But that terminology has changed a little bit as we've realized that acute GVHD can actually occur later in the course and chronic GVHD can occur earlier. But the skin is the most commonly affected organ in all forms of GVHD. And you're going to get more graft versus host disease in HLA unmatched donors and people who've undergone peripheral blood transplants rather than bone marrow or cord. And you're also going to see higher rates of GVHD in people who've had treatment with a myeloablative regimen. And the thought there is that there's more damage to the tissue, so the host is more susceptible to graft versus host disease. Things that I would note on the exam of acute GVHD, you can have these little areas of like follicular prominence. So the papules will kind of center more around the hair follicles. And this look where it's like really red and inflamed and has like palm and sole involvement, it makes me think a little bit more about GVHD as well. You can, again, get mucositis. And so it's kind of in the differential for that in a transplant patient. And then chronic GVHD can have a more sclerotic or kind of like scarred down appearance. The skin appears tight and often feels tight for the patient as well. Treatment for acute GVHD often involves topical steroids. If they're steroid refractory, the mortality rate may be up as high as 70%, which is kind of crazy. Chronic GVHD, we also treat with topical steroids and often oral steroids. Other therapies you can try, obviously in consultation with your specialist, is extracorporeal photopheresis. There are certain types of phototherapy that we use. And then more recently, JAK inhibitors have been used in the treatment of chronic GVHD with good success. Okay, I think this is our last case. So you have a 68-year-old with end-stage renal disease due to lupus, and they also have antiphospholipid antibody syndrome. They're on warfarin. They come in for an enlarging ulcer on their extremity for the past 2 to 3 months. What kind of things would you think about? Calciphylaxis, awesome. What else might you think about? PG, that's a good thought. We'll talk a little bit more about that. warfarin skin necrosis, great. I think that's a great thing to include with a differential, and I kind of was hinting a little bit about that with their antiphospholipid antibody syndrome. But I think that you are right that this is most likely calciphylaxis, and it has a little bit of what we call a stellate appearance, like it looks, the borders are really jagged. And there's obviously necrosis, and then there's this little kind of rim of erythema here too. So you perform a punch biopsy and it shows calcium deposits in the subcutaneous vessels consistent with calciphylaxis. And I include this picture here in part because you have to do a really big punch biopsy often to get the information to diagnose it. So it has to go pretty deep to see, the areas of involvement, which are all the way down here. And sometimes the punch biopsies just aren't diagnostic, even if you get a pretty good one. What is the recommended treatment for calciphylaxis? Great. Okay, so a lot of votes for sodium thiosulfate. So, oops, I actually changed my answers here, but actually all of these are probably appropriate depending on the situation. So IV sodium thiosulfate is kind of the traditional treatment of choice. You can do intralesional sodium thiosulfate as well. And then some patients may need surgical debridement if it's like really necrotic, and particularly if it's super infected, that area is not going to heal probably on its own. And so sometimes we will ask the surgeons to get involved for debridement. It is important to stop any calcium containing products, including calcium carbonate, and ideally switching to a non-calcium containing phosphate binder such as sevelamer. There was this recent study that came out within the past year that looked at the use of IV sodium thiosulfate in patients with calciphylaxis and actually found that it did not provide any mortality benefit, which is interesting. We still do it because it's really like the only thing that we have. And it, I think anecdotally does seem to help some patients. But that was a little bit discouraging, I think, when that came out. A couple other ulcers. Some of you brought up these on your differential already. What is this one on the left side of the screen? So I'll tell you what I'm noticing here is there are these kind of rolled borders. Like it's like if you were walking on this skin here and you stepped off, there's like a big ledge and it kind of rolls under. It's a little purpley appearing on the sides and then pretty like well demarcated. Does anyone have a guess? PG, great. PG, yes. And I had forgot to mention on our last case, warfarin-induced skin necrosis, I think is also on that differential for calciphylaxis often. So yes, PG for this one. What about the middle one here? What might you think about? This is on the medial leg. It's a little irregular borders. It looks like it has like a little bit of a wet base. Great, venous stasis. Yeah, so venous stasis, you're going to see more of a shallow ulcer off of the medial malleolus. You might see some background venous stasis changes like you see here, this yellow kind of fibrinous base. And then this last one over here. What do you guys think of this one? Infection, extravasing fasciitis. Okay. I probably would think a little bit less about infection, but certainly these ulcers can be super infected. What I see here is a kind of well demarcated, relatively round in some areas, ulcer that has this kind of like dry necrotic look to it, right? Like there's some like necrosis there. This looks like pretty dry exudate there. On the dorsal foot, arterial, great. I totally agree. And then you can sometimes see that on the lateral malleolus classically, but has that kind of punched out appearance, drier base, a little bit more well demarcated than the venous ulcer. Okay. We're going to quickly just go through some other things that come up a lot on the consult service. So, chronic lesions are usually better evaluated in clinic, even if they look like a skin cancer. Like a basal cell, we're just going to have a much easier time biopsying it in clinic with, better lighting, better room, better kind of flow with our MAs and support. So that tends to be able to be deferred to the outpatient setting, but please give us a call. We're always happy to try and get them in if need be. And then photos always help. I mean, both for these chronic lesions, but also for rashes. If you can take photos on your haiku up, like Dr. Colvin was mentioning, that is super helpful for us to triage and to also just get photos in the system that we can then follow to see how the rash or lesion or whatever it is has progressed over time. Blisters, you're never wrong to swab them. VZV, HSV are super common in patients who are hospitalized, who are under a lot of stress, oftentimes have some form of immunosuppression. And so if you think that it could be either of these, just swab it. It's a really easy test. Send for the PCR. And then I feel like contact dermatitis comes up like once or twice a week on the consult service. And this is one that I think that you guys are smart and capable and definitely can handle on your own. But we're happy to help if need be. In contact dermatitis, you're going to see a geometric shape. So you can see around in this example, it's really rectangular right around a surgical incision. Oftentimes it's due to an adhesive in hospitalized patients. They can get what we call an id reaction. So they get this contact dermatitis at the site where there is something in contact with the skin, but then their body mounts a kind of immune inflammatory response in other places in their body. So they get kind of like an eczema-like rash elsewhere on their body at a site that's totally distant from where that contactant has been applied. It can be irritant or allergic. When it's allergic, it's a type 4 hypersensitivity reaction, so delayed. And then the most important thing is removing the thing that is causing the reaction, and then triamcinolone, again, is your friend here. Put it on twice a day for a couple weeks until the rash resolve. When it is dressing related, dressings that may be a little less allergic are silicone dressings without adhesives at the border. So Meplex transfer is a really good one. And then sometimes we use those tubular elastic dressings that you sometimes see in the burns unit, but they're basically big nets that you can use to secure bandages in place. So you could even put just gauze and then put that little tubular elastic dressing around the person's arm or trunk and help it keep it in place that way instead of tape or adhesives. Okay, so that is it. My take-home points is derm is cool and skin is a window to systemic disease and can be a really useful tool for you as an internist. Think about the timing of drugs with rash onset and then call us if there are concerning features, but you can handle a lot of those uncomplicated drug eruptions on your own. Hem-onc patients are super sick, have a low threshold to consult derm, and rashes that pop up in them. And then you can do all the things, just like Dr. Colvin mentioned, but swabs, steroids, square rashes, you got them. Thank you. I'm happy to answer any questions or shoot me an email if anything comes up.